to use those skills in her career. I know it's not on here, but I know she's a full-time mom as well, with 2 beautiful children. And so she decided sort of, into her career to do a master's degree to see, whether she can contribute to the health system in a broader scale. And that's what the subject of her thesis is end of career practice patterns of primary care physicians in Ontario. And I'm delighted to be working with Sarah and Ivy. We are co-supervising Sarah on this project. So Sarah's using ISIS databases to help inform planning the human resources. Oh, and there we go. I'm useless. I don't know what you gave it to me.
Thanks very much, Lamont. So thank you for the opportunity to come and present at Research in Progress rounds. The research I'm presenting today will form the basis of my thesis for my Master's in Health Systems at the University of Ottawa. I'm in the second year of the program, and the research is very much in progress. I'm happy to have Simon and Ivy here today, and we welcome comments and suggestions about the research. So I am studying end-of-career practice patterns in primary care physicians in Ontario because I want to understand the process of physician retirement in order to make physician workforce planning more effective. Everyone agrees that aligning the supply of physicians with the need for the population for medical service is an important goal. But to date, no workforce planning approach has been very successful in doing this, and developed countries experience alternating shortages and surpluses of physicians. One of the things that hinders workforce planning is unreliable estimates of physician attrition from the workforce. A better understanding of how medical practice patterns change over time, the process of physician retirement, may be the key to improving these estimates. We have nothing to disclose. Today, I'm going to review background information about physician retirement and the physician workforce. I will discuss the research objectives and describe how a focus on end-of-career practice patterns in primary care physicians will help us to better understand the medical workforce. I will present my research questions, the methodology that we're using, the results to date and anticipated results, what remains to be done. I will discuss expected insights, limitations of the study, and the contribution that this will make to health workforce research. Historically, workers continued to work until they could no longer do their jobs. Until the latter half of the 20th century, workforce participation amongst older men declined steadily, likely related to old age pension benefits, the growing value of leisure, and increased participation in the workforce by women. This trend continued until the mid-1990s, at which point it reversed. In 1994, the expected age of retirement was 59. In 2002, it had increased to 63. As the baby boom generation, which currently accounts for a large proportion of the workforce, approaches typical retirement age, questions about workforce trends are starting to attract attention, and much research is underway across disciplines in an effort to understand various factors that contribute to the retirement decision-making process. Some of this research, although not all, concerns physicians. The literature suggests that in some respects, physicians are very much like other workers. However, there are some things about physicians that make them unique and that may have a bearing on their retirement decision-making. Individually, physicians have been found to see retirement as a transition, reflecting the considerable autonomy that they have in deciding how many hours they work, what services they provide, and what the content of their work is. Since most physicians rely on self-funded pension plans for retirement income, factors related to market performance and financial planning may have a role in retirement decision-making. Finally, Finally, the practice of medicine is often a vocation, and physicians identify their work as being an important aspect of self-esteem and a sense of identity coming from their work. They may feel a sense of responsibility to their patients and their work that isn't paralleled in other sectors. Collectively, physicians may not be comparable to other workforces. They have highly specialized skills. They provide essential services to the population. They work, in general, closely with other professionals to provide essential care. Their services are mostly publicly funded, as is their education, which takes a long time and is expensive. These are all things that distinguish physicians from other workers and that may impact their retirement behaviors. So, what do we know about physician retirement? In 2011, the Canadian Institute for Health Information asked Ray Pong, a researcher at Laurentian, to take a closer look at retirement. His report is entitled "Putting Away the Stethoscope for Good," toward a new perspective on physician retirement. In this report, he asked the question, what is known about physician retirement? And the answer, Pong says, the short answer is that we do not know very much. And that's the starting point for this project. One thing is clear, and maybe one of the reasons that we don't know very much about the physician workforce, is that it's a complex system with multiple, diverse, and interconnected parts. Each of these elements interacts with the others, and they all exist within the broader context of the health system itself. This is a dynamic system shaped by inflows and outflows to and from the workforce. Inflow to the workforce is well characterized. We know exactly how many trained physicians exist, and we know how many physicians join the workforce through migration. Outflow to the workforce happens primarily through physician retirement, although a small amount of attrition happens through migration and through death. Workforce planning models typically use retirement rates. X% of physicians retire each year to describe the retirement component of outflow. But retirement rates usually consider retirement to be a complete cessation of practice, when in reality, retirement can mean a variety of different things. Also, retirement rates consider each physician to be equal, when in reality, one can imagine the retirement of a busy physician with a large and busy practice having a bigger impact on the health system than the retirement of a minimally active physician. Estimates of outflow from the workforce have not been particularly reliable, and without good estimates of outflow, how can policymakers make good decisions about inflow? The goal of this project is to move beyond simplistic assumptions about retirement and to better understand outflow from the workforce. The goals are twofold: to characterize the process of physician attrition from the workforce and to generate knowledge that will facilitate prediction of physician workforce trends and enhance physician workforce planning. I propose that much can be learned by taking a broader view of retirement as a process instead of as a categorical endpoint. We can better understand this process by looking at physicians' practice patterns as they approach the ends of their careers before they actually reach the threshold necessary to be considered retired for the purposes of workforce planning methods. To do this, we need to look at how much physicians do, what they do, and who does how much and what. Because these three things are interrelated, they can't be considered in isolation. The goal of this research is to tease apart the how much, the what, and the who of physicians' end of career practice patterns. In order to do this, I have chosen to focus on primary care physicians. Primary care physicians represent half the physician workforce in Canada, and they provide approximately half of patient care. They deliver care in a wide variety of practice settings, which means that they have more work options at the ends of their careers, and so they may demonstrate retirement patterns that are different from specialists in other disciplines. As large numbers of family physicians from the baby boom generation approach retirement, their average age is about 50, Questions have been raised about how succeeding generations will replace them. Studying the practice patterns of family physicians in order to understand how the care they provide changes over time will help us to understand and plan this part of the physician workforce. This study addresses two specific questions. How do primary care physicians change their practice patterns as they age? And what factors influence changing physician practice patterns? Physicians' practice patterns will be characterized in terms of both workload, how much they do, and scope of practice, what they do. Specifically, the extent to which primary care physicians continue to provide comprehensive care. Changes in these variables will be examined over time. This approach will generate a dynamic picture of how physicians practice as they age, and will present opportunities to examine how and to what degree various factors influence physician retirement behavior. And I'll discuss those in a little bit. This is a longitudinal study of linked demographic and billing information of Ontario primary care physicians. The data come from the Institute for Clinical and Evaluative Sciences from ICES. The sample is composed of all primary care physicians eligible to practice in Ontario between 1992 and 2013. Once identified as being eligible and included in the sample, physicians are followed forward in time until they are no longer practicing or until the end of the study period. Sampling was initially conducted in 1992 and then was repeated each year subsequent in order to identify all physicians providing comprehensive care during the period, including those who start practices and physicians who migrated to Ontario. The project received approval from the University of Ottawa Research Ethics Board and was also approved through the ICES Privacy Impact Assessment process. Independent and dependent variables have been captured and will be used in the analyses. For independent variables, I have data on physician year of birth, gender, vocational training. I know whether these physicians were Canadian trained or international medical graduates, and if they did graduate internationally, the country of their medical school. I know physicians' practice locations, not specifically, but falling into three categories: major urban, non-major urban, and rural. All remuneration models for Ontario primary care physicians, except those working in community health centres, are included in these data. And I'm very fortunate to be able to include both fee-for-service physicians and those physicians who practice in a variety of alternate remuneration models in the analyses. This is unusual for these data. The first dependent variable is workload. The data from ICES provide 5 ways of looking at this: service volumes, payments received, full-time equivalent status, number of days worked, and panel size. We will include each of these variables in the analyses. The second dependent variable is scope of practice, which can mean many different things. In the context of this study, scope of practice is defined as the extent to which primary care physicians participate in comprehensive care. And ICES has a flag for this, and the flag requires physicians to work more than 44 days a year, to provide more than 50% of their care in core primary care services, and to have at least 1 billing per year in at least 7 of 22 activity areas. And these activity areas encompass most of what we understand to be primary care: general and intermediate assessments, diabetes care, mental health care, allergy shots, pap smears, etc.
So for those of you who are ICES scientists, you'll see this is a different definition than what you're used to. So it's been slightly updated recently.
Yeah, they've been close to it. It used to be 18.
But it's 8 out of 20, but it's just a little different. It's just been developed.
That's right, yeah. And in fact, it changed in the process of us organizing this research project. The definition changed.
Yeah.
So we had to kind of adapt a little bit to adapt to it, which we have. The change actually made the definition of comprehensive care to be slightly broader, and which probably is better for us. All right, so because the analyses are still in progress, I'm going to discuss the results in 2 sections. First, I'm going to talk about what we have found with regards to physician flow through the study, population demographics, and the definition of retirement. And then I'm going to discuss what we expect to find with regards to workload, scope of practice, and then the factors influencing practice patterns. So, we have identified all physicians eligible to provide primary care between 1992 and 2013. There are 21,240 of these. We asked the question, do these physicians provide comprehensive care at any point during the study period? If they did, then they were shunted into the left-hand box. There were 15,552 of these. Physicians who never provide comprehensive care at any time during the study period, 5,688 of them, were excluded from the analyses. For each year of the study period, we determine whether a given physician is licensed or not licensed, and if they are licensed, whether they are providing comprehensive care or not. If they're not providing comprehensive care, we ask what are they doing. They may be working more than 44 days, but doing activities other than comprehensive care, such as emergency medicine or sports medicine, or they may have worked less than 44 days that year. Now, it's important to note that physicians move between these bins from year to year, and that the flow of physicians between bins is really what this project is all about. We're looking for patterns in how physicians who are providing comprehensive care transition from the workforce into retirement. So, do they do this by doing something else, and then by working less, and then relinquishing their licenses? Or do they do this by simply going directly from the primary care workforce into not being licensed?
So can you tell within the databases when somebody's relinquished their license?
Yes, because the physician database we're using is the ICES physician database, and in order to be included in that database in a given year, you need to be licensed.
So many people will relinquish their license several years after they've finished clinical work. They
That's
kind of
right.
hold on to it just in case. And
Yep.
do you see that?
We see a not insignificant proportion of people who are billing $0,
Yeah.
but are still licensed. And we can speculate about why that is, but it may come down to that sense of identity and not wanting to really to experience the finality of giving it up. But we definitely see it. Okay, so now I'm going to describe some of the demographic trends that we found, and this is where I really need the pointer.
The pointer doesn't work on the screen.
You
You'd have to use the mouse if you wanted to.
Okay.
Oh, really? Yeah, it works on the wall. And
it does. It works fine.
So it doesn't reflect back. It just goes into it.
So bear with me, we'll go very slowly because it's a complicated figure and it doesn't animate. So what we did in order to look at the demographic trends over this time period, we took 3 separate demographic snapshots of our population, one in 1992, one in 2002, and one in 2012. And in 1992, these are the dark bars on the left side of each grouping. The median bars are 2002, and then the light colored bars are on the right side of each grouping. So what we found is that in 1992, the primary care workforce is relatively young. There are tall, dark bars in the younger age groups, and that the workforce is also relatively male-dominated. There's a preponderance of blue in those tall, dark bars. As time goes on, this baby boom bulge moves through the workforce, and we see tall, light-colored bars in older age groups towards the right side of the chart. We also see that the proportion of women in the workforce increases over time. The red bars get gradually larger, especially in the central age categories as time progresses. So this aging and feminization of the workforce is well known, and these are factors that are going to be important for us to consider when we start looking at practice patterns. So, although our main focus is practice patterns, it's necessary to have a threshold for retirement. In our study, physicians are considered retired when they bill $0 in current and future years. And this definition was chosen after we reviewed the literature on retirement in general and on physicians in particular. To assess the appropriateness of the definition for this study, we compared our primary definition of retirement with 7 other thresholds to determine the impact of varying the threshold on the estimate of the number of physicians considered retired. We chose 4 FTE thresholds, 3 dollar value thresholds, and license relinquished as the final threshold. We found that the most conservative estimate of physicians retired was produced using the license relinquished threshold, followed by the $0 threshold. We found that estimates showed good concordance overall, that they move up and down in concert, and that estimates were on average, produced by all thresholds, were on average within 19% of one another. So estimates of retirement appear to be fairly insensitive to the threshold used, and we're confident that our primary definition is appropriate. It's relatively conservative and appropriate for the study purposes. For other researchers doing work on retirement, knowledge of the differences between thresholds can guide the choice of an appropriate threshold for the question under consideration. So we're in the process of characterizing physician workloads over time. Using the 5 indices of workload that we talked about before, service volumes, payments received, FTE status, number of days worked, and panel size, we're examining what happens to workload as physicians age. The longitudinal information that we have will allow us to characterize physicians' career trajectories using age activity curves like the one you see here. From these curves, we hope to identify key career milestones, such as the period of peak practice activity, the period of phased retirement, and the actual point of cessation of practice. In order to help us characterize physician practice patterns, we're particularly interested in whether or not we can find an inflection point which, once evident, would predict retirement within a certain time period. We think this would be most useful from a planning point of view. Next, we will look at whether each physician continues to provide comprehensive care in the year following their inclusion in the sample. We'll triangulate this information with what we know about physician workloads to identify physicians who stop providing comprehensive care but continue working. We expect to produce a chart like this one, showing the proportion of physicians by age who continue providing comprehensive care. Those are the people in blue. The proportion who are retired, those are the people in green. And the proportion who are practicing in another setting. So if primary care physicians transition crisply from comprehensive care practice to retirement, those red bars are going to be very, very small. Either way, we will look more closely at the physicians who make up those red bars and ask the question, what are they doing other than comprehensive care? For example, are they giving up their offices in order to provide hospital-based care or surgical assistance, palliative care? Or are they like my family physician who retired this summer from her office practice but continues to provide student health clinics and sexual health clinics? We will examine a variety of possible activities, practice activities and settings, including anesthesia, emergency medicine, inpatient care, home visits, mental health services, nursing home care, obstetrics, palliative care, and surgical assisting. Having established how physicians' workloads and scopes of practice change over time, the next step will be to understand how various factors influence these patterns. Recognizing that the practice activity of physicians is influenced both by their age as well as by the age cohort that they belong to, it will be important to separate out age effects from cohort effects. To identify age effects, one might ask the question, how does the workload of 65-year-old physicians compare to the workload of 55-year-old physicians? To identify cohort effects, one might ask the question, How does the workload of 65-year-old physicians in 2005 compare to the workload of 65-year-old physicians in 1995? Stratifying practice activity and scope of practice milestones by physician generation, as seen in this table, will help us to see whether physicians' practice behaviors differ according to the generation to which they belong. A multiple regression analysis, including other variables of interest, physician gender, location of training, location of practice, and practice model, will also be conducted to determine the relative influence of these factors on physician practice patterns. I hope to be able to report results as follows. Physicians demonstrate peak practice activity between ages A and B. They start decreasing workload at age B and take C years before they're fully retired. Physicians take D years to decrease their workload to half of what it was at its peak. Primary care physicians tend to stop providing comprehensive care E years before stopping practice completely. And physicians who stop providing comprehensive care but continue to work participate in F, G, or H instead. This is all new information, things that we don't know, and that will be useful in informing workforce policy and planning decisions. The limitations of this study are mostly related to its use of secondary data. These data are only from Ontario, and while I believe that the findings may be generalizable to other primary care populations, I don't think that any conclusions about retirement patterns for specialist physicians can be drawn from this work. A further limitation is that only the variables captured in the ICES databases can be included in the analysis, so there are undoubtedly other variables that influence physicians' retirement decisions, such as spousal factors or dependence, that we just don't have information about. While ICES takes many steps to optimize data quality, each variable has its own strengths and limitations, and we need to be aware of that in our interpretation of the results. Also, data are only available since 1992. While this is a unique data set in physician workforce research, it pales in comparison to some of the other data available in other disciplines like economics or ecology. Because the data span a period of only 22 years, we will not have practice information for the full career of any single physician or group of physicians. So we'll have to piece together information from physicians at different stages of their careers in order to paint a picture of a physician's typical career trajectory. Finally, in the context of this study, the information available will be very useful for getting to the bottom of questions related to who, what, when, and where. But answers to the question of why may require some inference or further research. So, by exploring the questions, how do primary care physicians change their practice patterns as they age, and which factors influence changing physician practice patterns, I hope to characterize the process of physician retirement from the workforce, and to generate knowledge that will facilitate prediction of physician workforce trends and enhance physician workforce planning. I anticipate that this project will make a contribution to the field of health workforce research, and that these results will be of interest to workforce planners, policymakers, other researchers, and physicians themselves. I expect that this study will set the stage for further research in a whole variety of directions, and I look forward to changing the answer to Ray Kong's question, what is known about physician retirement, we now know a little bit more. Questions?
Well, as a baby boomer, congratulations. This is a very well organized thesis project, and it's part of what's so great about it is it's so focused and you're so clear on what you're doing and why. So my suggestions are not about your master's thesis, they're for your PhD thesis.
You're not going to let her retire, right?
Yeah, exactly. So your focus here, rightly so, relates to workforce planning. But I can't help thinking that if you included measures that dealt with quality of care, that you would be opening a whole new perspective here that might have implications for patient safety, might apply to situations other than when physicians are retiring from clinical work. such as chronic illnesses and so on. And so when people in their work patterns are only working very part-time, the risk is that you're dabbling, and maybe the quality of what you're doing is starting to suffer. And I think that figures largely into people's decisions when they're trying to figure out doing something really stupid. So I think it would add incredible complexity to what you're doing as a master's thesis, and I'm not suggesting that, but I couldn't help but think while you were presenting how that might have much wider implications than workforce planning. And then just one other friendly amendment, I think it would be a good idea, rather than talk about retirement, to say retirement from clinical care.
Yeah.
Because there's lots of things that physicians do, such as working for malpractice. They review things, cases, or in insurance companies, or God forbid, even research. So.
Okay, thanks for your suggestions. I think given the wealth of data at ISIS and the fact that they have been able to create linkages between this sort of information and lots of other kinds of information, that what you suggest is totally possible. It's large and ambitious and beyond the scope of this, but I think it's really interesting.
I think the medical research aid, the medical MRAs, medical regulatory authorities, like in Ontario, that would be the CPSO, would be really keen to pay you while you did that work.
Yeah,
But
absolutely.
right now, they don't provide, there's no link between the MRA data and ICD
No,
data.
but I think there would be, I think there could
We
be,
were working on that.
I think there would be an openness. I mean, they're not going to transfer and link data that has to do with being found incompetent and being disciplined or something. But there's lots, they have information that I'll bet you they could be convinced to, who knows?
So thank you, that was very interesting, and I'm, like Bill, one of your retirees. And it's interesting, just one little side point is that I kept my license while I was 5 years in Nova Scotia and then came back. So there are some explanations. I looked like I stopped practicing, but I didn't. However, the one thing that, as a chair of family medicine, that really worries me was that 1/4 of people who you identified who do not do comprehensive care, which I wonder, I mean, that's not your study. It would just be very interesting to know what that 1/4 is doing, because it affects our training programs and what we're meant to be doing.
It actually is part of the study. We're going to take those people and say, who are they, where are they, and what are they doing? And
It has a huge effect on work.
over time. Is this, are these new grads? A preponderance of them recently graduated, or is this a phenomenon that we see throughout the full spectrum of 22 years of producing family medicine residents, that some of them just go that direction, and we don't know yet.
Well, it will be very helpful for our training programs to start to look at what we're doing. I can say that our impression is our PGY3 and emerge means people become emergency physicians. They do not do family medicine.
And this may be them. So these people are initially captured as people who are primary care physicians, but that 25% may be the people who actually end up doing mostly emerge. We're
Begs
not
the
sure
question
yet.
what we're doing for training.
Surgical assists, stuff like that.
Well, people don't do that full time, I don't think.
No, as in the transition.
Yeah.
Yeah, so that's part of the question, and we'll be able to identify those people who fall into the red bars.
Yeah.
What are they doing? So they are not doing comprehensive care anymore, but
What they're
there's
doing clinically.
What
I
are they
really
doing?
want to stress that, because they're often finding other things to do that aren't clinical.
And again, we're limited by, ISIS has no data on academic
fair
work,
enough.
nothing
That's-
on research,
right.
nothing, so you're absolutely right, it's what are their clinical activities?
Is that the red bar? Is that in that 3/4 that you're using, or is that, I'm just remembering your first, did you include the 25% that you said you weren't studying in the red bars? So the red bars are in addition to that 25% that you took out.
That's right. The reason that those people aren't included is because in order to make it into the red bar, you had to, at one point, have been providing comprehensive care. And so the red bar is somebody who has stopped doing that.
Yeah.
And moved into doing something else.
So we have actually a quarter who
Are not part of this study, so the ones who don't provide comprehensive care and never enter.
They don't actually come in. The only thing we're going to do is say, who are these people, where are they, and what are they doing?
Yes.
But they don't actually come into any of the other.
Yeah, I understand that.
Yes.
It would be interesting to know why did they never go into primary care? What's the issue?
Just that, so congratulations, it's very clear, well-structured, well-organized, reflecting on some comments up to date. Just a couple of thoughts, way beyond the masters probably, but just your thought for further studies, or as Bill was saying, I think some of the
Postdoc.
So I'm wondering about, on the CPSO, every year, as you know, when we renew our licenses, they ask us about, we have to fill out the percent of what is it that we're doing, and that does include research and teaching and administration and other things. So the data is actually there. It would be really interesting for the people who are phasing out their clinical work to be able to link it with that. So that would be one thought. Another possible source of data, and I'm not sure about the exact variables that were collected, but the physician health survey that was done was quite comprehensive, I believe, and had a lot of information about what other activities people are doing. So that would be another possible.
They also had whether people plan to retire.
Yes, that's
It'd be
right.
interesting to know if people who say they're planning to retire actually do.
So that they actually,
Yeah, I mean,
That's
that's,
some data. Is that like from the CCFP?
That would be from the old NPS.
the National Physician Survey.
Okay,
Yeah.
but they're,
so it's definitely in the literature that other people have studied that, and what they find is that people say they're going to retire, and 2 years later, they're not
They
retired.
change their mind.
And then the third thought I had, which may be a little bit more controversial, but I think is in the realm of possibilities of ISIS, is in terms of physician health, what Bill was referring to, people are getting sicker, they have chronic conditions, etc., would be, and that again is, I think it would be a ethical hurdle definitely to get through that, but to anonymously look at those physicians' use of medical services and their prescriptions, etc., and calculate their chronic disease score and see if there's a correlation, because that is clearly there, and I don't know, you must be able to link it, because I think physicians also have a unique identifier, but then you're going from looking at them as providers to looking at them as patients.
We discussed that.
You discussed that, yeah.
We don't know how feasible it is.
Yeah.
I don't know ethically if they'll ever let us do that.
Yeah.
Identify physicians as patients in the ISIS data.
I bet no one's ever asked.
I would
I would think
give
we
it
were
a
asking.
shot.
And I do the chronic disease scores, right? We do that all the time.
That's very interesting.
No? And see if their burden of, let's say chronic disease or, substance use.
Well, it's all about the healthy health worker, right? So
Exactly.
Yeah, and it's also.
Anyhow, so
So just explaining why.
to see, is are there correlations with, because if you did a regression over looking at who is decreasing their practice rate, and then you've got a bunch of unknown, undocumented variables, I'm sure that would explain a part of it, for sure. Not all, but would explain a part of it. Well, that's it, it's all aggregated, anonymized, right, so.
I know, but you want to actually link it to their practice patterns. That's the thing that I think, I think if we wanted to get aggregate data on, physicians' health through the ISIS
No,
data?
no, we individual level of data.
Maybe we can't tell you, probably their position number, their own IKN.
What's that?
Their position number probably is not linked to their IKN.
I don't know, that's what I don't know. Whether you can link the practitioner number to the unique identifier as a patient.
I'm not sure either.
I'd be surprised. That's true.
Well, you got a lot of information in terms of
One of the slides that you had up before, you know the one that's showing the trend over time where you're comparing the different thresholds?
Yes.
Because maybe this group can give us some insight about that little Beacon Valley.
Okay.
Yeah, it's a little hard to see, so maybe you can walk us through a little bit what these are. So we're finding, and also maybe tell us what the y-axis does it start at 0, and maybe this group can help us understand that pattern that we're seeing. And don't focus on the end of the curve, because we know what's happening at the end of the curve, why it goes up. It's because we don't have subsequent
The
years.
end of the curve is actually adjusted. So, so basically these curves show numbers of physicians considered retired according to a given threshold. So we have a population, we reach into the population and say our threshold is 0.33 FTE. Based on that, how many physicians are considered retired? We get a number. And we say our threshold is 0.25. We reach into the population, we get a number. For
So
how
at the
many
bottom, we've got years.
That's right. So this is 1994 out to 2011, and the different colors are different thresholds. The darkest color that's closest to the bottom is relinquished license, and so basically that produces the lowest estimates of physician retirement. And we see a certain amount of variability, particularly around 1997 and 1998. So what we saw was that retirement, estimated numbers of retired physicians in 1997 plummeted and then rebounded in 1998, and by almost all measures. And
Does the
we're
stock
not-
market look anything like
Yeah, we
that?
talked about,
Yeah, so that's one of our side projects is to, we're gonna look more at
similar trend,
2008.
what's happening?
Well, you know, if you think you have enough money to be able to retire and you aren't enjoying your work or something, you probably are going to retire. But then if most of your assets evaporate and
But then you retire the next year, so that the point is, it can flatten out, right? So here, and it's just so weird, because here are so few of them, so regardless of what definition you're using, so
Yeah.
don't worry about which curve you're looking at. Here, all of a sudden, there's so many fewer than you would expect, because otherwise, this is pretty flat. Okay, let's not look at this at the end, but this is pretty flat, but here they don't, and then the next year they all do, so if it was the market,
Yeah.
Well, I'm wondering if it's a true effect or is it a coding of the data or definition
thought
of
about that,
that?
but.
That is
I
upstream from what you're doing,
Yeah.
like in the ISIS data about how
I
they,
would
whatever.
know some of the policies. instead of
Or
just
the
like-
policies, that would not be the two
Yeah.
things.
So one of the thoughts that we've had is that it's a regulatory thing.
Right.
So, I mean, stock market is definitely possible, but, and I haven't quite figured out how to go back and find this out, but if the college says, here are the requirements for you to maintain your license, and I think they found this in the UK, then physicians say, well, yeah, I'm not gonna do that, I'm gonna retire, and a whole bunch of people retire en masse.
Or a significant increase in the fee, the college
fees,
fees.
yeah, so-
A lot of the dormant people might say, like, forget it, you know?
Okay.
So one of the
If
parts,
they, whatever, the fees double or something.
Yeah.
I think you need somebody from the CPSO on
Yeah.
their advisory
Yeah.
committee.
Yeah, absolutely.
one of the things that we're doing as part of this project is making a long timeline, so time along the top, and then along the side, potential factors, so market, financial related factors, regulatory factors, cultural factors, kind of like medical.
And the other opposite, the economics from the other perspective, there was I forget when the year was, but the family doctors in Ontario got a big raise at one point, which
Yeah.
might have encouraged people to keep working, you know?
Yeah, so one of our goals is to make that timeline and then take these data and try and line them up and see whether we can get any insights from that.
Well, it's
into the-
important to know then what are the policy levers that can enable people to stay in or that
Yeah.
Yes.
excludes them. But it's also about having appropriate data for workforce planning. So for example, when they moved towards revalidation, I was stunned actually that 10% of the physicians on the register done in the UK. So there's
Validation.
revalidation. It's, yeah, they call it revalidation.
And they just said, forget it.
Yeah, no, they just, well, there are some of them that lose it on revalidation, they try, and others just say, oh, I'm not gonna bother with this.
Or is it
No, it's an OSCE kind of thing, so, yeah. So there's practice audit, OSCE, there's a variety of different things. But that was fascinating because here are all their workforce projection models before this came in, and then they've got 10% fewer physicians. I mean, I'm curious as to how, how this impacts the whole junior doctor strike and everything, but this is important stuff.
So these are physicians who may have been around a long time, have large, busy practices. We're not talking part-time people. who just
Physicians, I think, work very hard at trying to stay safe. And, regardless of age and proximity to retirement, for example, in obstetrics, once people are delivering less than 10 babies a year, they seem to self-police very effectively and get out prior to there being problems in terms of outcomes. So.
But it's interesting, Michael Klein did a study on low-volume family medicine obstetrics. I'm not sure how long ago that was, but he did say that, you have to maintain a certain volume, but even low volume is still fine.
Well, but it's because people. I agree with you, that literature shows that people seem to be able to figure it out and quit before they got a problem.
But there was a study that showed that on internists that, experience counts for something. That they showed that the outcomes between new physicians in internal medicine and experience, the outcomes were similar. So it was to show that, you do need to keep up to date, but experience also.
But I think that the people who get into trouble with the CPSO and stuff are more likely to be older.
There's also those who, like in surgical oncology, that's a known fact. So if a surgeon does a lot of that type of procedure, their outcome is much better than those who do few. So that's.
But I think surgical
So
specialties.
the other one too, right? People who deliver more than 300 deliveries a year are charged extra, even per delivery, in the U.S. by their insurance companies because they get they don't take it as seriously and they.
But we should mention that, when Bill is talking about looking at the quality of care towards the end, maybe as their practice is petering out. And the reason why it's important, not just because, maybe your practice peter out, you're not thinking as well, but we did a study where we saw that individuals with a small panel size, the quality of care tends to be lower. So we don't know whether that's because they dropped their panel size as they were getting close to retirement. We didn't look at the age. We just looked across the board. So, and we were doing this, we were doing this because we thought that, the quality of care would be good for a certain level, and then at one point, there'd be this threshold, there'd be this shoulder. And that's not what we found. We found, in fact, that the biggest drop is in the
And those are people that could be potentially at risk of providing care that doesn't meet the quality standards, just based on
the licensing authorities are going to be very interested in this work. Also, well, I guess they're into workforce planning too.
No.
So much?
No.
that's
mandated all.
Oh.
We can hardly get them to collect data.
I'm not sure.
Okay, any last question or comment? I just want to be respectful of people's time. Good, okay, thank you so much. Oh, please remember to check out the evaluations.